We have about 25 minutes for the panel. So for those who have questions, line up at the microphones, please.
Thank you, Larry. Is this on yet? Okay, very good. I'm Mia Levy at Rush University Medical Center. First of all, this was an absolutely fabulous panel. I really enjoyed hearing all of these perspectives. In particular, I'm going to ask John this question first, but I think almost anyone on the panel can address it. You mentioned this program that ASCO and the NCI put together around care teams, and this was this wonderful workshop and all this effort and energy back in 2016. It's now 2019, and I haven't really seen much else in the way of research funding to move this forward, or even in the EHR space. You know, this isn't, although it is an area of science, both of these topics of usability and care teams are research focuses, and we don't necessarily have that expertise always inside our oncology provider world, and we need to bring that expertise in, but we need to entice them to come in with incentives to study this problem and get funding to do it. And I'm just curious if anyone on the panel is aware of what reasonable next steps could be done to help continue to promote this type of very important work beyond our local institutional experiments that we're all trying to do.
I was going to make a comment about that, actually, the 2016 reference document in the JOP. From a clinician point of view, I agree with you. I want to stand on top of a mountain and scream about the necessity to think more about team care, and we need to know more about that. I know the NCI has dedicated some resources to this. I'm not so sure about where the RFAs and that process of that process is. Maybe Dr. Carlson, Sue-Anna?
Thanks for the question, Dr. Levy. Just to briefly, this is Sue-Anna from ASCO. We haven't made any funding available, and as Dr. Cox mentioned, I know NCI is, I believe, putting a proposal together. One thing that we've incorporated it into is ASCO, we have a clinical affairs department under the leadership of Dr. Steve Grubbs, and they're going out and doing assessments of oncology practices. And one of the things that to help oncology practices understand how to configure, et cetera. And one of the things they've incorporated into that assessment and feedback mechanism is this idea of teams. And so I think we're starting to infuse it in things that we're doing on a pragmatic level, but the research point you make is a good one, and I don't think there's a lot of additional effort in regard to that piece of it.
I think from this policy forum, this may be one of the high things to press, because it, as Bob said, I like his words, poach them. It has to be done intentionally, and I nearly want a new word, because we all talk about being teams, but what we're talking about is a completely different entity in my view.
I just might follow on, if since we had an ASCO representative, perhaps it could be a focus at the annual meeting or at some of the other quality symposiums, even just continuing on this dialogue with groups being able to bring their voice in other forums than this one today, and continuing on that story.
I think that's a great point, and maybe, Sue-Anna, you can bring that back to ASCO leadership. I mean, that would be a great opportunity to get people together in some sort of workshop or focused group.
Yeah, and actually, as I'm sitting here, I'm thinking of all the other things going on at ASCO that I should mention. But one other, and another thing that the Clinical Affairs Department is doing is we have this quality training program, and that also is bringing teams to ASCO to do quality assessment, and the team aspect is a big component of that as well.
Yeah, good, thank you.
Hi, I'm Diane Portman at Moffitt. This question is for Anthony Beck. Hi. I know that you wear a lot of different hats in your care of patients, and you're also known as a communication skills building guru. And I'm just curious, as you think about burnout and resiliency, what role you feel that enhancement of communication skills building for the hard talks we all do has in building any resiliency?
Yeah. Your question, Dr. Portman, is right on target. I do think that building skills for oncologists and oncology team members to have the difficult communications that they need to have is clearly a issue that builds resilience. The data isn't as clear as some of the things that I showed, so I didn't push on that for this particular thing, but clearly it's there as an important place that clinicians who are in cancer find meaning and find a kind of renewal, honestly, every day. So I think you're absolutely right that those are really important issues. I know that Jill Lowry is going to speak a little later about this in the day today, and so she'll probably return to that. But I think it's a really important issue of if you look at the resilience literature, where do people find the meaning of their work? It's really important and something not to lose sight of. So thank you.
Great.
This is Eben Rosenthal from Stanford Cancer Center. I'm the service line director there. I really want to congratulate. There's an excellent set of talks. And my question is about the combination of compliance and the electronic medical record. It seems as though a lot of the compliance issues were generated pre-EMR and are following into that. And then the EMR is developed, which has then created an entirely new structure. And I'm curious if these can be addressed together. Yeah.
You're a tall guy. We just want the microphone a little bit closer to your mouth. Great.
Thanks, Ruth. Is this better?
Excellent.
Okay. Great set of talks. My question is about compliance and the EMR and the frustrations that physicians have and the chain of workflow basically has become that the physicians or advanced practice providers end up entering everything because it has to be entered by the physician. So the order monkey is now raised to the absolute top of the license. So it's creating a lot of workarounds and throwing people at problems that are not necessary. So my question is where do we go from here for that? How do we work with compliance organizations as well as with the EMR to really change that workflow?
Well, I'll step in. My conclusion, looking at this situation, I've been working as a clinician. Have worked with both Cerner and Epic, and I've talked to a variety of people in the informatics space preparing for this talk. And my overwhelming conclusion is that our current system is not working. My overwhelming conclusion is that we are at a point where we need some kind of regulation to create some real progress, because without some real leverage to create that progress, the kind of progress you're talking about, we will continue to have the same glacial pace of change that we have had. I mean, honestly, I personally have more confidence that we are going to change global warming than the electronic health record. And that's kind of a problem, right? So I think you're absolutely right. Thank you.
I'm not even sure how to respond to that last comment. I might just add, a lot of what we do for documentation and compliance, I think we would all agree is low-value work. And it goes back to trying to decouple documentation from payment and some of the other regulatory components. And I understand why they evolved there, but maybe we could de-evolve them to some extent. Harold?
Yeah, maybe I'll just add one other thought, which is rather than maybe focusing on changing the picture, look at a new picture, and that is around a lot of those issues that you described have to do with the fee-for-service world, quite frankly. And the opportunities, I think, are just to move away from that and to move into value-based reimbursement world where, in fact, there are payments that go to those that are delivering care in a comprehensive way, and to allow those caregivers working in integrated teams to allocate those dollars to achieve the best possible results for each of the individuals who happen to sometimes be patients that they're caring for. And that's ultimately how you wind up solving the problem, because everything we do up until that point becomes a halfway solution to try to get there. And we've seen over and over and over again, they've been frustrating and frankly not all that successful.
And just a quick comment. So with value-based care and moving in that direction, it will be important to, as everyone knows, is then to look at what the documentation requires for that and how is that going to fit into the work system. And so the EHR is a tool, and if it's designed to focus on the documentation for regulatory pieces, it will override and be extremely frustrating if we're using it for clinical documentation. So I think moving forward, look at what we've learned from history and what the intent of the EHR was, and with all those various stakeholders, how do we move forward and look at, well, what's the intent of the EHR in this next generation with different payment sources, payment bundles, and is it being designed to support those? And are the workflows being put into place in the organizations to support that data, that information getting into the EHR? So just follow up on that.
And then I put a staccato to it, and this now I'm out of my space very well, but I look at Mia and I think of Jeremy, and I saw a article that he wrote. I don't know if you were on that or not, just published here about thinking of clinical documentation like a wiki, and that the team is, there's a entire team input that creates documentation, not so much transactional, and it was thought-provoking for me.
Brenda?
Brenda Nevajon, CEO of ONS. Actually, to ping off of what you just said, even in the paper days, the redundancy of our documentation. So this idea, whether it's a wiki or whatever it is, of an integrated documentation to me makes a lot of sense. And we certainly hear patients talk about they keep getting asked the same questions by so many of the team. So actually what I got up here to say was not that, but your comment made me think about that. What I was going to mention is that we've talked about culture, community, and team. Those came out in several of your presentations. Some of you referenced all three. And I think that we all nod to that, but to John, what you were saying, what do we really mean by a team? For the longest time, we always talked about, oh, we're a family. And I don't hear us using that here, but that still is language that's used a lot in organizations. And many years ago, I heard a leadership presenter talk about avoid that because of the power of words, and that families tend to be more dysfunctional than functional. And so the lessons learned, I forget, I apologize, I forget who referenced about learning from the military. Learning from coaches. I mean, there are a number of leading coaches in this country who have written books about the structure of teams, that issue of practice, that issue of clear delineation of roles, so very clear. And yet we use language without really understanding it. I really appreciated the first couple of presentations that tried to really talk about the principles and the different definitions. So I thank you for that.
So we have global warming and dysfunctional families. Neil?
Yeah, hi. Neil Meropol from Flatiron Health. Really intrigued by this discussion. We are an electronic health record vendor, but we're also a research entity that generates real-world evidence based on data from electronic health records. And we're currently building out quality analytics on top of our EHR as well as on top of Epic and other EHR systems to allow quality benchmarking across, to generate standards across the country, but also to measure at the individual practice or hospital level. And I was really intrigued by the comments of the panelists regarding the levers that could help companies like mine move forward this effort in terms of building in quality analytics on top of EHRs. I heard regulation, I heard payment being tied to this. And if in fact this is where the puck is going, and I think it is, what do you think the key levers will ultimately be? What do we need to do to get there such that EHR vendors like Flatiron are incentivized to build out the systems that are required to accomplish these goals. So, Harold, maybe you could kick it off.
Yeah, so it depends on how far down the ice you're looking at that puck. I would say this, and we've talked forever about this triple aim of access, quality, and cost, right? And I think somewhere down the line it's going to be a different conversation. It's going to be about engagement. It's going to be about wellness, and it's going to be about value at the end of the day. And if I were designing systems for the future and having had an opportunity to do that over the past 4 years or so, I would say that's what my obsession would be over. Because quite frankly, and I heard in some of the earlier presentations about patients coming to us to meet with members of our care team. And you think about, from a patient's perspective, what that is like. Making the appointments well in advance, driving hours to get somewhere, doing the loop-de-loop around the parking deck to get an appointment, and then being pleased that you could get 10 minutes of face-to-face time, because as many have said, that poor providers, clinicians spending so much time in front of a screen. And then, we have process measures of quality, and, I think back a long way back, measuring all kinds of things around quality that are really about process. Did you wash your hands? Did you get readmitted? They're important, don't get me wrong, because you can get infected, and if you get readmitted, it means something probably went wrong. But at the end of the day, all of us want a measure of being well. And the things that make us well are not just determinants like healthcare per se, but it's the things that all of a sudden, fortunately, people are talking about. Behavioral determinants, social determinants, environmental determinants, and we've just talked about climate a minute ago, right? There's a lot of things going on here, and of course, genetic determinants. Those are the measures we really want to look at in terms of looking at a state of wellness per se of individuals who, as I said earlier, happen to spend part of their time as patients. And if we can't do that, how do we really achieve what is any individual's aspirations for health and wellness, even if they have a chronic illness that we've successfully cured and avoided death, but now we have to work with them to allow them to live at the top of their life for the next several decades with that chronic illness. And ultimately, it's not about what we spend on things, because as I said earlier, if we're spending $400,000 a year on something, but that has enormous value, isn't that really what counts at the end of the day?
So if I could just interject here, Neil, don't go away. I want you to finish. But, I think one of the challenges for information that Harold might want in the payer side, and you might want, and I might want in the quality side, is so much of what's in the electronic health record is not in a structured format that both could feed back to the clinician and help them in their decision-making and care of the patients, and feed into other sources to automatically measure quality in a way that's not an administrative burden. I mean, I think the oncology care model has been a great experiment, but it's a heavy lift from the administrative burden point of view, and probably not scalable and sustainable. And we're not in a place right now where our EHRs can supply a lot of the key data that would answer a lot of these questions. And I think that's one of the things we need to think about as a profession.
Yeah, I guess I was going to ask a follow-up question to Harold. So in terms of measuring well-being, that might include patient-entered information like patient-reported outcomes. So are you thinking that we as a society should be going in the direction of routine collection of measures of well-being that a payer might ultimately use to determine reimbursement for care? Sorry to be provocative.
Yeah, I think we need measures of well-being. And, in the old days, it was things like Healthy Days, for example, a 30-day recall test. We announced late last year, the Aetna Wellness Index assessment, which we're doing in partnership with the Harvard School of Public Health. And it looks at 6 domains of wellness. So it's physical health and emotional health, not a surprise there. But the other 4 are financial well-being, social connectedness, purpose, and character. And we have this online assessment tool of roughly 84 questions that allows us to collect that information voluntarily by a patient and by a member, and then coming up with what are individualized solutions or interventions to address those 6 different determinants. And those are the kinds of things that become very valuable because the individual then has a huge hand in defining what health is for them as opposed to what perhaps I might think is health. And then ultimately organizations that are really successful, to get to your question, in doing that well, wind up receiving the support, the financial dollars, because in a value-based world, if you're successful at the end of the day, then financially you would hopefully be successful as well.
Hi,
I'm
my
sorry.
name is.
If I can just interject up
sorry.
here real quick, sorry. Just one thing that struck me as we were talking about this is whenever we start to capture these metrics and being pushed through the healthcare system, I think we have to be cautious or at least consider, are we addressing these metrics as healthcare, as clinicians? So of course we're looking at wanting to address physical well-being, mental health well-being, but do our patients see this? So if we're going to be, I guess, asking these questions, do the patients see that as a healthcare team, we're trying to address these things? So if for their well-being, as someone was talking this morning, the tremendous transportation issues, if we're not talking or acknowledging or about the transportation issues, are we going to have a disconnect between what we capture in this measure and what we've been delivering in the healthcare system? So just, I think I'm not disagreeing with doing that, but that's something that we may have to, we're going to have to build up within, I think, our healthcare environments. Sorry to interrupt.
Great. No, that was great, Mary. So we're running very short in time, so any questions need to be short and focused.
I'll save it for later.
No? You sure? I don't want to scare you away.
I just wanted to ask how your organizations are thinking about incentive alignment. Are any of your organizations thinking about going away from the RVU-based approach in order to try to realign those incentives around teams and away from burnout measures? Incentives, I should say.
Not mine. Go ahead, John.
Well, from the Parkland system, UT Southwestern has a medical service contract to provide professional services to Parkland. And just in the last 2 years, we've begun to try to take a bucket of money out of RVUs and begin picking 2 or 3 measures on which to base that money. I hate to tell you what those measures are because it's a bit embarrassing getting people to use, to stage patients in the EHR. Every patient is staged, but it's in the text note, use our clinical decision support. We have a pathway program, that kind of thing. So we've begun the very process-oriented stuff, just on the cusp of it.
Bob?
I think that's where a lot of organizations are. We need to be kicked in the butt by our payers, I think.
Bob?
Just a side comment that I find it interesting that you're incenting physicians based upon performance where they're duplicating work in the electronic record.
Right.
With that optimistic note.
Hi, I'm Hildy Dillon from the Cancer Support Community. So I would just like to say from the patient advocate and patient experience perspective, I think that this conversation is very, very important, but also incredibly scary. Because what I'm hearing is that, and I think Dr. Bach may have said this, there really needs to be measurement of what patients are experiencing when they're in your practices, and it's not unique to oncology. It's all over in medicine today. That people are not ignorant to the fact that there isn't a lot of interdisciplinary management of their care, and they have to become their own navigators if they have the capacity to do that. So I think we have to, I understand cost effectiveness, and I understand that everything has to get paid for, and we're all working on ways to make that happen more efficiently and better, and to address disparities and access to care. But I think you really have to have the patient experience in this equation. So I do think it's worth measuring that, and it should be part of the accountability of those teams. What is the experience for our patients?
Yes, absolutely. I mean, one of the things that the current patient experience measures don't really capture is the experience of what is it like to be a patient of a team. That is actually not, that's not one of the current measures. You're absolutely
And this
right.
is just a really quick comment that's related to the last three things that have been said. I think we also not just have to collect this information, but we have to honor and use it in some way. One of the things that patients and advocacy groups are really concerned about sometimes, everyone, the idea of having patient-reported outcomes, great. You absolutely need them. It's not an option to get it. It's something it should be required. But then it sort of falls to where? And nothing's more frustrating than not being asked than being asked and then realizing that nothing happens with it. So I think we have to think about this on a number of levels.
I think that's very helpful. So I wanted to end by just making an observation. It seems to me that the things that we've talked about this morning fall into two buckets. There's the bucket really that everything is contained within our organization. And I think that Bob and Tony and John all spoke to that. These are things that creating the culture, the leadership, the self-reflection, can happen within a practice. It's not governed by billing requirements. It's not covered by anything else from the external point of view. And the reason I bring that up is because I think often, it's one of these things. We're blaming everybody else for all of our woes. And I think we need to think about what we can do within our own institutions and with our own practices. And then the other bucket, obviously, are things that we need to partner with. And one example might be, how can we better use an interaction between the EHR and payers to do a lot of the stuff that now people are doing with high administrative cost. And it's hard for me to believe that we can't get to a better place in that respect. And that would not only relieve a lot of the burden from our clinicians, but you're paying people in your organization to answer the phone and deal with all those pre-auth calls. So, it's a lot of wasted administrative resources on both sides of the fence. So that's the other thing. So some of them have to be partnerships with, with our practices and outside organizations, or require national will to change. And some of the things we can be very specific about, that it's really on our shoulders to go back to our practices and change the way we do things. And I think Bob and Tony and John summed up a lot of those issues and a lot of the opportunities. So with that, we're going to end this session. We would like to be back at 1:15 to start sharp for the afternoon sessions, and I assume that lunch is right outside these doors. Thank you, everybody.